Good morning, everyone. I hope you all are doing well. This is my first video on this channel, and before we dive into the content, I would like to take a couple of minutes to introduce myself and explain the purpose of this channel. My name is Dr. Awais, and I'm nearing the completion of my extensive training. Now, this channel has two main objectives. First, to assist you with exam topics, and second, to bridge your gap between the theoretical knowledge and its application at the bedside. Now, what happens as medical students and trainee doctors, we often memorize a vast amount of information. While much of this knowledge is crucial for patient care, a significant portion is also geared towards passing exams. My channel aims to support you in both areas. One, succeeding your exams, and two, application of this theoretical knowledge into the clinical aspects. Now, without wasting the time, let's begin our discussion on subarachnoid hemorrhage. Now, the simplest way to define the subarachnoid hemorrhage is blood in the subarachnoid space. Any patient who is coming to us in hospital with any neurological deficit or any neurological problem, whether the patient is in ED or we come across that patient in the ward, the first thing that struck to our mind, could it be stroke? And when we are considering the stroke, we start thinking of ischemic strokes, intracerebral hemorrhage. What we don't immediately think is subarachnoid hemorrhage. And the reason is that subarachnoid hemorrhage accounts for only 5% of the stroke. But I tell you what, though it accounts for only 5% of the stroke, mortality with subarachnoid hemorrhage is really high. About 50% of the patient with subarachnoid hemorrhage die. And out of the remaining 50%, at least half of those patients are dependent or have some degree of neurological deficit when they get discharged from the hospital. Now, the most of the patients who develop this subarachnoid hemorrhage are between the ages of 40 and 60 years, and it's more common in the females than the men. Now, there are few causes of subarachnoid hemorrhage that you need to remember. The topmost cause you must remember is aneurysms in the brain. In fact, if you can remember three causes, that would be great. The first one is aneurysm in majority of the cases, AV malformations, and trauma. What you need to remember is the pathophysiology, the complications of aneurysmal subarachnoid hemorrhage is totally different from the subarachnoid hemorrhage that happens due to the trauma. What we're going to talk about in this presentation is subarachnoid hemorrhage due to the aneurysm. Now, these aneurysms are commonly found in the circle of Willis. And when these aneurysms rupture in the subarachnoid space, they lead to a specific list of complications which are we going to discuss in this presentation. You can see the picture in front of you. It's a circle of Willis, and these aneurysms are particularly common at the bifurcation of the vessels. And the risk factor for these aneurysms and rupture of these aneurysms are hypertension, atherosclerotic, cocaine use, and connective tissue disorders like Ehlers-Danlos syndrome. So the next question that comes to our mind is how these patients present. Most of us know these patients present with severe headache, often described as the worst headache of their life, and it's a common symptom. But what other symptoms should we consider? As I have mentioned already, subarachnoid hemorrhage is a cause of stroke, so any sort of loss of consciousness or any drop in GCS or any neurological deficit can be the presenting symptom of subarachnoid hemorrhage. A few more things you need to remember is because there is a blood in the subarachnoid space, so there will be the signs of meningismus. Blood in subarachnoid space will lead to meningismus signs, which are neck rigidity, photophobia. Because there is a blood in the brain, there will be raised ICP. So the features of raised ICP, which could be headache, nausea, vomiting, neurological deficit, or papilledema. So in a nutshell, patients can have symptoms of raised ICP, and patient can have symptoms of meningismus because of the blood in the subarachnoid space. Supposedly, a middle-aged female in whom subarachnoid hemorrhage is more common comes to you with these symptoms which I just mentioned, and you start thinking what I'm going to do next. The first thing you would do is obtain a non-contrast CT of the brain. The brain CT scan imaging is excellent for detecting blood in the subarachnoid space. And you can see the slide in front of you where you can see the blood within these fissures. The streaks of blood within these fissures, and that's how the subarachnoid hemorrhage typically appears on a CT scan. Now, while the CT brain is very effective, it's sensitive and specific in identifying the blood on the brain, provides you quick, immediate results. But still, it's important to note that it can still miss an extremely small number of cases with subarachnoid hemorrhage. So what are you going to do in those small number of patients where the clinical suspicion of subarachnoid hemorrhage is high and CT brain hasn't shown you the blood on the imaging? What you're gonna do is you're gonna do the lumbar puncture, and you're gonna do the lumbar puncture after the 12 hours of the onset of symptoms. 12 hours after the onset of the headache, you're gonna do an LP. And the most important thing I'm gonna mention, when you're gonna do the LP, you always take these 4 bottles whenever you do the LP. You're gonna specifically label the first bottle and the last bottle. What happens when we do the LP, our first bottle can have the red blood cells because of the traumatic lumbar puncture. What the 4 bottle can do is it can exclude that traumatic LP. What we're looking in lumbar puncture is we're looking for the breakdown products of red blood cells, which could be bilirubin, which could be xanthochromia. So label your tubes, send the first lumbar puncture tube and the 4th lumbar puncture tube for bilirubin and xanthochromia to rule out subarachnoid hemorrhage. Now you did a CT scan or a lumbar puncture and you found out this patient has subarachnoid hemorrhage. What's the next step? As I mentioned to you earlier, the topmost cause of subarachnoid hemorrhage is aneurysm. So you must obtain CT angiogram after you have done the CT brain to find out the cause of this subarachnoid hemorrhage, which is most of the cases aneurysm within the circle of Willis. And this CT angiogram is gonna help you to find that aneurysm within the circle of Willis. Now this CT angiogram is really good in finding those aneurysms, but some of the aneurysms might still be missed with the CT angiogram. And in those cases, the scan that you're gonna use is DSA, digital subtraction angiography. Many of you would be wondering, what is this DSA? For now, just remember DSA scan is used to delineate the cranial structure from the intracerebral vessels so you can better identify the aneurysms. All right, so the middle-aged female comes to you with a headache and some degree of low GCS. You perform a CT brain, it showed subarachnoid hemorrhage. You did a CT angiogram, it reveals an aneurysm in posterior communicating artery. What do you do next? Now remember, the acute management of subarachnoid hemorrhage is very important. If you're sitting in exams, the very first thing that should pop up from your mouth is, you will always say, I'm gonna start with A, B, and C. And the same thing is true if you are at the bedside also. The very first thing you need to do is you need to look at the airway. Now I'm gonna make a separate video, how do we manage an airway, but for now just remember, you would need endotracheal intubation for any patient whose GCS is less than 8 or his GCS is worsening for more than 2 points. The other two indications you must remember when the tracheal intubation is indicated is if there is any problem with the oxygen saturation of the patient which cannot be managed with ordinary face mask, or if the patient CO2, whenever we say ventilation we are mentioning CO2, or if you do an arterial blood gas and the CO2 is more than 6, you need to probably intubate the patient. So airway come first, and when I'm talking of airway, does this patient need intubation? And if the GCS is less than 8 and is dropping, GCS of less than 8 or GCS is more than 8 and it's dropping, or there is any issue with the oxygen saturation or arterial CO2, or if the patient is seizing, you probably need to intubate this patient. So the patient GCS was low, you called an anesthetist, anesthetist came down and stick a tube down the throat. And he started maintaining the oxygen saturation and starting maintaining the CO2 level. What's the most important thing in subarachnoid hemorrhage is this very particular part about the blood pressure, which many of us don't pay attention to. Remember, this patient has subarachnoid hemorrhage from a ruptured aneurysm. And that aneurysm, ruptured aneurysm, is an unsecured aneurysm. That aneurysm can rupture again. And only thing which is gonna prevent that aneurysm from rupturing again is systolic blood pressure till we secure this aneurysm. So if your systolic blood pressure goes above 60, chances of this patient to rebleed in the subarachnoid space is really high. And I can tell you, if this patient is gonna rebleed again, the patient who came with a GCS of 14 or 15, in a moment of time, this patient is gonna drop her GCS further, and the effects of that drop of GCS and rebleed are gonna be really bad. So you must make sure the patient blood pressure, systolic blood pressure, is less than 160. In fact, if you can take one message from my presentation today is, if you come across this patient with subarachnoid hemorrhage, until their aneurysm is secured, make sure their systolic blood pressure is less than 160. That's it for today, and I'm gonna meet you in the second part of this presentation. Thank you.